the main, well, can you hear me all right? Okay.
Yes, I can.
So the main reason is that when the enterocytes and brush border are depleted, the digestive enzymes are also depleted. So there's only capacity to digest small amounts of food at a time. The other reason is that stretch of the stomach or stretch will increase the pancreatic enzyme secretion and stuff, so put more pressure on the pancreas, whereas less stretch will result in less pancreatic and gallbladder impact. Other than that, I can't really think of anything that is kind of rate limiting, but I guess also the dog's or cat's food aversion. If they kind of eat a big meal and then feel nauseous, they might not eat it afterwards. But
yeah, no, that I was really fascinated to hear that, because that's been a policy in medicine for probably generations.
yeah,
In human medicine. My father taught that when I was a child. So.
Oh, really?
Yeah, so that's going back a good few decades.
Yeah.
And now that, like so many other things, we've got the reason for it.
Yeah.
I mean, at the time, I think, or my daughter anyway, described it to do with the gastrocolic reflex. But I think that's probably a bit simplistic compared to what we know now.
Yeah, I'm not sure about that, because cats don't have a gastrocolic reflex, do they? It's only dogs and humans. Is that right?
Yeah, I couldn't answer that one accurately.
Yeah. Yeah, I'm not sure. And I guess we're referring mostly to dogs with the small frequent meals, because cats just do whatever they want anyway.
True. I think the other thing as well that Liz might have, if I'm remembering it correctly, was in relation to protein losing enteropathy as well, keeping like a higher protein gradient in the lumen to prevent protein loss or something like that. I think that was so like regular feeding to kind of high quality protein. So the lumen is high protein, so the gradient is higher there than it is in the I guess like the lacteals. So the proteins.
Oh, I see. Yeah, so between meals where the protein level would drop normally, then the proteins would leak out of the lacteals into the lumen down at concentration gradient. Ah, that's a good point.
That was another point that I remember leaving with last time. But anyway, yeah.
Yeah. Yeah, it's a really, really good point, actually. So if you can keep protein in the lumen all the time, it's going to keep the flow in rather than out. Cool. All right. So who read the chapters?
I'm afraid I have to confess I didn't, because when I went looking for my book, I realised that it was well out of date and I left it behind in one of the many places I've been. I haven't got around to ordering another one yet.
Oh, that might be a good Christmas present for you, Jeff.
There's an idea.
So I'm going to give Max and Josh homework, because you've got memberships coming up, and the next topic for next fortnight is raw feeding and unconventional diets. And I would probably put that in as an exam question if I was a membership examiner. So I would like you guys to read the Edinger chapter, but also read the AVA statements. So see what the Australian position is on raw food diets, and do a bit of a literature review on the risks and benefits of raw feeding. Okay?
Okay. Sounds good.
Good. So really these chapters, what we were covering is the nutritional impact or the nutritional considerations with heart disease, renal disease, and cancer. So I thought if we start with heart disease, has anybody heard of cardiac cachexia?
Yeah. Oh, yeah.
Yeah. What is it?
I suppose my understanding is it's increase in energy consumption because of the heart is not doing properly. That's why you get cachexia, because you get like catabolism of your body.
Yeah, Which part of your body?
I would say, I guess, it'll be musculoskeletal.
Yeah, exactly. So it's a lean muscle mass loss or lean body mass rather than fat mass. And sometimes we can have quite sort of rotund patients with really profound emaciation or muscle condition loss, particularly on epaxial muscles, which is where it's most prominent in obese patients. Why does it happen?
Just poor perfusion, I'm guessing.
Interesting. Maybe a part of it, but then the kind of what then happens as a result of poor perfusion is inflammation, basically. So tell me some inflammatory cytokines that you think might be responsible for this.
Like interleukin 6, that's something that I guess.
Yep.
Interleukin 1.
Good. That's a big one. Yeah. It's
Yeah.
documented to be increased in dogs with congestive heart failure.
That's the two that I can guess.
What about one that doesn't start with an interleukin, starts with a T?
Like
Human necrosis factor.
Excellent. Yeah, TNF alpha. So TNF alpha and interleukin 1 are both increased in dogs with congestive heart failure. What impact does that have on the heart function? Does anyone know?
Does it form more like a fibrous tissue?
Yeah, absolutely. It causes fibrosis, myocyte fibrosis, and actually hypertrophy as well.
Right.
So it exacerbates that remodeling. The other impact it has is actually a negative inotrope, those inflammatory cytokines. So they're actually going to decrease contractility of the heart and impact heart systolic function directly. And the other thing with inflammation, and this is sort of a little bit controversial because we always used to say sick patients need more calories than well patients, and that's kind of a little bit up in the air now. But inflammation increases energy requirement. So if there's increased inflammation, then those cells, particularly the cardiomyocytes, are going to need more nutrition, and therefore being in a negative energy balance is going to be detrimental to their function. So if we're looking at supplements and diets and things for patients with cardiac disease, knowing that cardiac cachexia is caused by inflammation, what might we be able to use?
Could you use things like, well, I guess in regards to things like inflammation, maybe like antioxidants?
Yeah.
Or, and just like a high or easily digestible protein source so that they can kind of keep that level up. And maybe one more like heart specific kind of minerals like taurine, those kind of things.
Yeah. Yeah, very good. So we'll go on to taurine and sort of mineral supplements and stuff like that. But really the main thing, antioxidants, if we talk a little bit about that, is with their direct effect on the inflammation. Are you going to just put some turmeric in there?
Turmeric?
It's turmeric, yeah.
Yeah, I noticed that's coming up a bit more often. What about really, the fish oil type things, the omega 3s?
Absolutely. So dogs fed omega-3s had decreased inflammation, which actually led to an increased appetite. So they were more likely to maintain their body condition and eat those high digestible, good quality proteins that we were feeding them if we treated the inflammation directly with omega-3s. So, yeah, I sort of think, there's so many medications that you send home with a patient with heart failure. I mean, what difference could omega-3s possibly have? But I've certainly had patients that were cachexic and we were having trouble maintaining their body condition even though their congestive heart failure was under control. And that's something that we can certainly add in those patients, which might help.
So the precipitating cause there is the poor perfusion of the muscles, I gather. Is that right?
No, it's actually a lot of factors. So there's the direct trauma in the endothelium with the regurgitant jet, which causes inflammation as well. And then there's the valvular inflammation as well. And then perfusion on top of that. So if you've got just decreased blood flow to the periphery, you're going to have increased inflammation and cell breakdown at the periphery, and that's going to contribute to increased inflammatory mediators.
And then it becomes a vicious circle by the sound of it.
Absolutely, yeah, exactly. And then you get the negative inotropic effect, and then decreased perfusion is perpetuated. The other thing that they didn't really talk about in this chapter is that a lot of dogs, I mean, obviously we see left-sided congestive heart failure most commonly, but we also see right-sided congestive heart failure, which causes venous congestion and congestion through the gastrointestinal tract. So when we've got sort of decreased, I guess, drainage from the gastrointestinal tract, there's probably going to be effects on absorption of nutrients. Increased pressure to absorb those nutrients through up the portal system into the liver, then we're going to end up in a calorie deficit or in a nutrient deficit. So all of that stuff happens once congestive heart failure develops, but not early on in the course of heart failure or in the course of valvular disease. So what about if we talk about taurine now? What's the role of taurine in cats?
I think when they're deficit, they get like dilated cardiomyopathy.
Good.
And that's related to the diet that we gave was in deficit, I think.
Yes, yeah, exactly. So do you know, Jeff, you would probably remember when feline diets were frequently taurine deficient, and
Yeah,
DCM was...
That was back in the 80s.
Yeah.
85 to 90 is when I did my residency, and it only really just been discovered then.
Yeah. And does anyone remember why cats are so much more vulnerable to taurine deficiency than dogs?
They can't make taurine.
Good. Excellent. Yeah, but dogs can. So taurine's an amino acid, which is essential in cats and non-essential in dogs. So cats with taurine deficiency will develop DCM, and they will respond dramatically and almost completely to supplementation with taurine, if that's the case. Whereas dogs, what diets would you, if you had a dog with DCM, what sort of diets would you be suspicious that could be taurine deficient if you were talking to an owner?
The big diets, like the boutique, exotic, and grain-free diets.
Good, yeah. So I shouldn't have said taurine deficient then, but yeah, what diets are associated with DCM in dogs? So in dogs, it's less clearly understood what the role of taurine deficiency is in those diets, because if you test a lot of those diets, they're actually taurine. There is enough taurine. But high fiber diets, did you say that?
No, I did not.
Yeah. And lamb and rice diets have reported in Edinger in this chapter. But we don't fully understand why these diets are causing DCM, whether it is taurine, like decreasing utilization of taurine, or whether it's another nutrient that's causing that. There are specific breeds of dogs that get taurine associated or taurine responsive DCM without actually being necessarily deficient in taurine. So if you measure a taurine level in their blood, they're sometimes sort of normal, but if you supplement them with taurine, they might respond. Can anyone think of any breeds?
Like Doberman.
They're actually non-taurine responsive, the Dobies, but they're a breed that are genetically predisposed to DCM for sure.
Golden Retriever, I'm guessing.
Yep, good. And probably the other big one that we've seen is Cockers, American Cocker Spaniels. So they're talked about a fair bit in the literature. So Dobermans, you mentioned, they get the genetic DCM, and there's virtually no point testing for taurine in a Doberman because it's almost always genetic. I mean, it can't hurt to do it, particularly if they've had a questionable diet history. Taurine has some kind of pharmacological effects of its own, so it's actually a positive inotrope, and it's an antioxidant. So whilst I say unlikely to be taurine responsive, as in it's not going to cure its DCM, it's probably going to have, supplementation is probably going to have some positive impacts on the heart. So it's probably not the wrong thing to do. Taurine also regulates myocardial calcium cycling. So it's really quite similar effect to pimobendan, obviously a little bit less dramatic, but in dogs with DCM, even if they measure normal taurine, it probably isn't the wrong thing to supplement them if the owner's not overwhelmed, obviously. So why don't we move on to fat, talking about fats in dogs with congestive heart failure, so they're already in failure. If you looked at a patient with a body condition score of 2 out of 9 and a patient with a body condition score of 8 out of 9, which would have the worst prognosis in congestive heart failure?
Well, the fat one, the fat one does, but I'm not sure that I can give a reason for that. I think the fat dogs also don't exercise because, again, the vicious circle. And exercise has been shown to be helpful for cardiac health and many other healths.
Yeah. So dogs with a higher body condition have longer survival times. The main reason is that they're much more resistant to cachexia. They've just got that much more in reserve. So whilst obesity brings forward onset of congestive heart failure, it actually prolongs survival once congestive heart failure is there. Does that make sense?
It does, but I just find that's interesting.
I found it really interesting as well, and it's really that just having a little bit more fat in reserve, which makes a big difference to them.
I once met a very fat Dutch lady who survived the war, and she said that's what she said, that the skinny ones didn't last under occupation when they were all starving, but the fat ones did.
Yeah. My grandfather-in-law was a POW, and he was 80 kilos and 6'7", and he stayed the same body weight and condition through the camps and then home for the whole rest of his life. It was just unbelievable that he survived it because he had nothing in reserve. Anyway, we digress. So the only other sort of factor with fat is that we sort of talked about the fatty acid or the omega-3 fatty acids with their benefit with inflammation. The other sort of paper that's relevant to talk about is in boxers with arrhythmogenic right ventricular cardiomyopathy. Does anybody know what impact supplementation with omega-3s would have in a dog with an arrhythmia, a boxer with an arrhythmia?
Is it like membrane stabilization so they don't get arrhythmias?
Yeah, so they actually get less arrhythmias. It's really therapeutic in boxers. So certainly something that's worth adding in, particularly so many owners want supplements and that sort of side of the input now. So it's kind of nice to know that there's actually some evidence behind that now. So what about sodium in congestive heart failure?
We don't want it to be too high.
Yeah, absolutely. Why?
Because it's going to increase our preload.
Yeah, good. So just fluid retention, basically.
Fluid retention.
Yeah. So if we sort of use the like sort of grading system, say we're talking about a patient with degenerative mitral valve disease and they're not in congestive heart failure yet, they've got some remodeling, they've got some like fluid retention, but they're still stage B2. Are you going to restrict sodium at that point?
I think about because it's disease, isn't it?
Sorry, say again.
So I thought I would, yeah, because it's TB, it's in disease stage, so I think I wouldn't risk of fluid retention, so I would say low sodium diet.
So that's exactly what my instinct would be. But what is the effect of sodium restriction on hormones?
Would increase aldosterone.
Good, excellent. Yeah, so it switches on RAS if you heavily restrict sodium early in the course of heart failure. So the recommendations are to feed a like normal sodium diet, so not a high sodium diet. And the important thing there is that the recommendations and the kind of restrictions on sodium can vary by sort of 20-fold. Excuse me. So I would always just double check with the owner what diet they're feeding them, particularly what food they're feeding a patient. And if it's one of the kind of supercoat one, which has very high sodium levels, then I would sort of bring it back in. So essentially from onset of congestive heart failure, but not before, you want to have sodium of less than 80 milligrams per 100 kilocal. And then once you're getting a bit of frusemide, refractoriness to frusemide, so getting up to the highest frusemide they can tolerate, then you can do quite heavy sodium restriction. And that's going to decrease the amount of frusemide that's required, or increase the impact of the frusemide that's given. But sodium restriction before that point doesn't impact outcome and may exacerbate onset of failure due to activation of RAS. So I thought was very interesting. Yeah.
So it's like, generally speaking, you want to wait till congestive heart failure, and by that stage, RAS is already activated anyway. And then what you're trying to do is, because you can't really fight that very easily, just restrict sodium then. Whereas previously, okay, that makes sense.
Yeah. And then what about potassium with congestive heart failure patients on high doses of diuretics? What's going to happen with potassium levels?
Plummet.
Yeah.
Go down. Yeah.
Yeah. So particularly cats, I think, are more sensitive to the hypokalemia. But obviously, you just want to make sure the diet's not deficient in potassium. Okay. So what about B vitamins? Would you have considered them with heart disease? I wouldn't have either. So apparently, particularly in cats with congestive heart failure, they're often B vitamin deficient, probably because of the increased loss through their bowel with congestion, because they quite often get right and left sided failure. So decreased absorption and increased losses in the bowel. So supplementation can potentially improve appetite in cats and also improve outcome due to sort of antioxidant effects and things. And the only other one, a nutritional kind of component that they talk about is carnitine. Does anyone remember what carnitine's job is? Matt?
No. I think they bind with the free fatty acid. That's
Good.
well, I add carnitine for the cat that had the hepatic lipidosis.
Oh yes, yeah.
Yeah.
So it just lets fatty acids into the mitochondria.
Mm.
So it's a sort of cofactor in facilitating energy via the fatty acid pathways rather than via the carbohydrate pathways. So improves energy consumption in the heart. There are reports of familial carnitine deficiencies causing DCM. They're pretty rare, but some people supplement carnitine and L-taurine with DCM patients just to be sure, essentially, because it's not something we can measure in blood. All right, so last bit is renal disease. So there's obviously, like, I think we're a little bit spoiled with nutrition, and I found these chapters really hard to really pay attention to because we've got great diets that we can just prescribe and we don't really have to think about what's in them. But more and more I'm seeing clients saying, well, I want to give this treat, or I want to home cook, or I want to give a raw food diet. And I guess it's good to then review what components do we need to think about in patients with specific diseases. So are you guys happy with the format of just sort of going through the different nutritional components?
Mm-hmm.
Do you want to do? Yeah?
Yeah.
Okay. I feel like it might be giving you an excuse not to read the chapters.
No excuse. Sorry, Anna.
Yeah, we should read it, yes.
To be fair, Max only found out about rounds last night, so he probably didn't have time. Okay, so let's talk about renal failure patients. What's their body condition typically? Poor.
Mm.
And so if you were kind of saying to a client, okay, I want to really focus on diet and nutrition, what sort of body condition score would you like your patient to be aiming for?
Like,
hopefully 4 out of 9.
Yeah, exactly. Right in the middle.
Yeah, 5 to 6 has the best survival time. 5 to 6 out of 9.
Okay.
At diagnosis of renal failure. So you want them pretty fat, pretty on the upper end of the healthy weight range. And then again, it's just having more in reserve, isn't it, survival time wise? So obviously the calorie component, like you can't feed them a really low calorie diet because they're just going to have to eat so much more to hold condition. So make sure that the diet is calorie dense. What about fatty acids in renal disease?
I think it's meant to be quite good, and particularly I remember reading it's quite good for things like glomerulopathies.
Good, yeah.
In particular, I think very similarly to what we were talking about with the heart. So for its antioxidant type effects, so all those kind of what do you call it, polyunsaturated fatty acids, PUFAs.
That's a good word. So as far as, can you remember like omega-6 and 3s?
Yeah, there's a ratio. You need like a, I don't remember the ratio, sorry, but there's I know that there's meant to be a ratio, and I think it's like, I'm going to get it wrong, more 6 than 3, but I could be wrong. Yeah.
Wrong way.
Probably the other way around.
It's 50-50. So essentially most foods have majority of 6 in it just because it's cheaper and easier, and most patients don't have a requirement for increased anti-inflammatory levels. The other thing is that apart from like very specifically formulated veterinary prescription diets, you're never going to get up to an anti-inflammatory level of omega-3s in a commercial food. So supplementation might be important in these patients. And do you remember why the omega-3s were important in glomerulopathies, so anti-inflammatory effects? There's one more effect that they have, which is close to my heart.
No, I thought it was more just mopping up more than anything. But no, sorry, I don't know.
Inflammation. No, that's okay. They've got the antithrombotic effect as well.
Oh, okay. Bless your heart.
Yeah. So they just, one of the kind of causes of progression of glomerulopathies is that you get inflammation in the glomerular capillaries, and then you get clots forming in them, and that, like, if you remember, the glomerular capillaries, one capillary glomerular tuft comes down and then it supplies blood to the whole rest of the nephron. So if you get a clot up the top, you lose the entire nephron. So if you can decrease the amount of clots, which omega-3s have been shown to do, it's going to make a difference to progression of renal disease. So 2 indications really for omega-3s in these patients, and just remember that even if a food says it contains increased omega-3s, it's probably not at the anti-inflammatory level, and supplementation might be required if you're not feeding a specific renal diet. All right, so let's talk about protein in renal disease. If you have a patient which you've diagnosed with a mild azotemia and low USG, and it's stage 1, IRIS stage 1, what are you going to recommend nutritionally for that patient as far as protein restriction?
I feel like this is a trick question, because instinctively, like what we've been taught is a renal diet, which is low protein. But I feel like that's not actually good if we're trying to aim for good body condition score.
That's
so I feel like my answer is wrong, and I know it's wrong, but I don't know why.
You're exact. You do know why. It's to do with the maintaining body condition. So if we feed a renal diet, which is protein restricted in stage 1 IRIS renal failure, they will survive a shorter time period because their body condition becomes lower faster. So we want to keep them on a normal nutrition diet or normal protein content diet until they tip over into stage 2. And what sort of protein should we be using? This is such a stupid question, sorry. Just highly digestible. Like, we don't want them to have to eat a lot of protein and feel really full to get not many calories out of it. So to make it as kind of high quality as possible. All right, what about why do we do protein restriction in the higher levels of renal failure?
Isn't it mainly to try and reduce urea production, breakdown of protein?
Yeah. So what's creatinine?
Creatinine's a muscle kind of byproduct, which is a normal kind of metabolic process, and it should be relatively constant, and we can kind of measure glomerular filtration rate based on how high or low that is.
Good. Yeah. And what about phosphate?
Phos. Sorry, I said phos.
Yeah, sorry.
Phosphate. It's a mineral, and is primarily excreted by the kidneys. So if that glomerular filtration rate decreases, then we're going to have less phosphate excretion.
Good. All good answers, and bringing it sort of together is that the 3 things that we sort of recognise in our azotemic patients are all byproducts of protein catabolism, so breakdown of protein. So urea, creatinine, and phosphate are all byproducts of breakdown. So what if we fed a really high protein diet? What might happen to what would you expect to happen to our azotemia?
Worsen?
Yeah. Absolutely. And what's the downside of that?
If it gets high enough, it can make them feel quite sick.
Absolutely. Which means that they then don't eat as much. Yeah, exactly. And the owners, obviously the pet's quality of life, but the owner's observable, measurable kind of observation of their quality of life is quite obvious. And then it's obviously they don't drink as much because they're nauseous, they become dehydrated, the kidneys get less perfusion, and it really does cause progression. So that's where protein restriction is important. I think sorry, Jeff.
I've noticed over the years that you can get dogs that are in renal failure with high urea and creatinine and are not really sick. And then you get others that are really sick with much lower urea and creatinine. So there's something else going on.
Yeah.
And I don't know what it is.
Yeah. It's a really interesting point, actually. You sort of make your own conclusions along the way based on your experience and stuff. So I've got a theory on this, and it's completely just based on my observation. And I think that animals are very tolerant of azotemia if it progresses over a really long period of time. So the worst azotemias I've seen, where the creatinine is at 1500, have been in dogs born with renal dysplasia, and they've always been azotemic. That's just their normal. And they're eating, drinking with a creatinine of 1500. Whereas patients that have developed azotemia quite fast, so, that patient that you put on frusemide and the creatinine goes from 100 to 300 overnight, and all of a sudden they're nauseous and won't drink and really unwell, that's where I feel like they're intolerant to that level of azotemia or uremia. Do you think that's your experience as well?
I can't say. I'd have to look at it in future cases, but it makes sense logically.
We had one patient with a creatinine over 2000, and it actually started having seizures. It had a uremic encephalopathy, and we didn't have the bloods back yet. So this dog sort of went into its seizures. We were waiting for the blood test, and I went to intubate it, and I pulled open its jaw, and it bent down as I went to intubate it. So it was a dog with renal dysplasia who'd been azotemic for its entire 2.5 years of its life, the creatinine over 200, and it had such bad renal secondary hypoparathyroidism that had rubber jaw.
Wow.
Yeah, it was a once in a lifetime case, I think. So that why don't we then use that case as to start our discussion on calcium and phosphorus, or calcium homeostasis, in renal failure. So we've talked about protein restriction, but what about phosphate restriction, and why is that important? Phosphate specifically, not the sort of impact on azotemia.
So if you had high phosphate, because the way it binds with calcium, does that mean you'd have low calcium? So if you keep phosphate normal, hopefully calcium will also bind normally.
Good, yeah. So the balance is really important, because quite often you've got phosphate creeping up and you don't also want calcium creeping up. You've got to keep sort of calcium low so that you're less likely to get saturation. But what about renal secondary hypoparathyroidism? How does that develop?
You get a lot of calcium. I think you get a lot of calcium loss, so the parathyroid kicks in trying to maintain that normal level of calcium in the blood, and it takes a lot of it from bone through osteoclastic action. So it's just kind of keeps drawing from the bone from there. The other part of that is, I think, vitamin D. What's the word? Transformation? No, it's where it's basically I can't remember what the word is, but it's changing vitamin D to its active form, which involves in absorption of calcium, which happens in the kidney, which gets calcium absorbed from the gut. So you've got two kind of points of where calcium can be lost. Yeah.
So what about, In renal failure, you mentioned that vitamin D is transformed from vitamin D to calcitriol in the kidney, which is vitamin D3 is its active form. What's the kidney's capacity when there's reduced functional renal tissue? What's the kidney's capacity for producing vitamin D?
Oh, it's lower.
It's lower, yeah. So vitamin D is low. And normally, if you've got high levels of vitamin D or normal levels of vitamin D, what impact does that have on parathyroid hormone production?
It should keep it normal, I think, because because it can get a lot of the calcium. Oh, no, actually. So I guess parathyroid hormone also increases vitamin D production. Sorry.
Other way.
No, other way around, yes.
Well, sort of other way around. So you've got decreased renal capacity to produce vitamin D. You end up vitamin D deficient. Normally, vitamin D inhibits parathyroid hormone. So vitamin D causes calcium absorption, and therefore you don't need the PTH. So normally vitamin D inhibits parathyroid hormone, but in the absence of that inhibition, the parathyroid can produce a lot more hormone, or the parathyroid kicks in to increase the calcium level and doesn't rely so much on vitamin D. So where the phosphate comes into it is that phosphate actually inhibits formation of vitamin D. So not only have we got decreased capacity to produce vitamin D, we've also got phosphate inhibiting the production of vitamin D. So we end up with vitamin D levels absolutely tanking. So that then causes renal secondary hypoparathyroidism. Like you said, very well, good answer with the effect of parathyroid on bones and things. So clinically, and this isn't sort of talked about in textbooks very much, if you had a patient with renal secondary hypoparathyroidism, which bones would you want to x-ray to check for sort of density?
I think it might be long bones, but I'm probably wrong there. Actually, I'm not sure. Like your femurs and stuff.
Yeah, so long bones, you'll see thinner cortices, but the mandible, that rubber jaw, seems to be particularly susceptible to renal secondary hypoparathyroidism, as opposed to nutritional secondary hypoparathyroidism, which tends to be long bones and axial skeleton, but not mandible. So nobody really understands why. Well, I don't understand why, and I haven't read it anywhere. I'm sure someone's got a theory, but renal is jaw, and nutritional is the axial skeleton. So I'd x-rayed spine and long bones of a dog I was suspicious of nutritional. All right. Are we happy with what we need to consider in a renal patient's diet?
So what would you recommend in a stage 1? Because like inherently in GP, you're like, oh, kidney disease, give kidney diet, which renal is really wrong.
Yeah.
But what would you do? Would you just say, come back in 3 months, repeat azotemia, keep doing what you're doing, add lib water, do your thing?
Pretty much, yeah. I would make sure that they're on a good quality diet. So a lot of senior diets are a little bit protein restricted as well. So I would just make sure they were on an adult maintenance diet rather than a senior or renal specific. The first time I diagnose an azotemia, I always recheck it pretty quickly afterwards so I can plot how quickly it's progressing. Because if you've got, for example, like a nephrotoxin in the diet that they're eating or something like that, or they're all of a sudden, I don't know, got decreased renal perfusion because they've actually got heart disease that we can't hear, bloody cats keeping things secret. You know, if it's progressing quite fast, you want to know that early. So if I do azotemia check 6 weeks to 3 months down the track and they're pretty stable or mildly increased, I'll say, okay, it's chronic renal failure, and then put the long-term plan in place. But if I've detected an azotemia for the first time, then I'll usually check it sooner.
Yeah, okay.
But yes, essentially normal balanced diet plus water in that stage 1, but often we're diagnosing them stage 2 and up, in which case renal diet is indicated.
Cool.
I have one question.
Yeah.
That's kind of always confused me, and I'll admit I haven't really kind of looked too far into this, but what about your protein-losing nephropathy patients, when they're losing, quite large amounts of protein, and they often will have, renal changes as well, and an azotemia.
Yeah.
What do we like? I'm kind of my mind's telling me that we should be making sure they're getting adequate protein.
High protein. Yeah.
Yeah, but then it kind of conflicts with trying to kind of manage the azotemia.
Yeah, absolutely. So that's a really tricky conundrum, and what we'd be wanting to do is to address the causes of the proteinuria and decrease losses as best we can. So the types of renal disease where we see really profound protein loss are usually glomerulopathies, which are usually caused by either genetic or inflammatory causes. So we can treat the inflammation. We can decrease the glomerular hypertension with medication. So we want to decrease the pressure within the glomerular capillary without compromising it. Find the balance. Hey, very
like
hard.
The efferent arteriole to try and that's like benazepril type thing.
Yeah, benazepril and also amlodipine. So if we've got systemic hypertension secondary to the glomerulopathy, we want to make sure that's not just exceeding the 160 mark where the glomerulus can't filter it anymore. So managing systemic hypertension and systemic inflammation is going to be really helpful in stopping or limiting protein loss. In inflammatory forms, genetic forms, it's really hard, and you've just got to balance. So obviously if they're hypoalbuminemic, that's going to be a really negative thing for them prognostically. So we want to titrate the protein that we're giving them to manage their albumin levels, but also not exacerbate the azotemia. But yeah, a very tricky tightrope to walk. Unfortunately, we see them so rarely in Australia, whether it's the breeding or whether it's just the caseload, but we very rarely see genetic glomerulopathies. Would you agree with that, Max and Jeff?
Yes, but that's right. Yeah, so my brain was connecting with polycystic kidneys there, but there isn't a connection, no.
Max, have you ever seen a genetic glomerulopathy?
As in like renal dysplasia?
Well, specific like glomerulopathy, like one of the like malformed glomerulus, which with very high urine protein levels.
No, I have not seen that. No, I think commonly we've seen like primary glomerular disease because of membranous inflammation or like mineral change disease, but no, I haven't seen any genetic or congenital yet. No.
Yeah.
I suspect it may be more common in America. Would that be right?
I think so. That's where all the papers are from. So it's a really good consensus statement on the glomerular diseases. It's pretty old now. It's 2013, but there's a really good summary of all the different forms of glomerulopathies that we see and treatment recommendations for each one. And so many of them are completely irrelevant for us because the breeding just isn't in Australia. So it sort of sounded, I read this paper thinking I'm going to see this all the time as a specialist, and then I haven't seen any. What a waste of brain space.
No.
It's valuable. Okay, so we'll just do finish off renal disease. I'm not sure I understand. Oh, sorry. Siri's got something to say about that. So what about, I just want to talk about potassium quickly, because a lot of these patients have what happens with the potassium levels with renal disease?
If it's
okay, let's say,
but yeah,
I'm going to be more specific. What happens with potassium in oliguric renal disease?
Goes up.
Yeah. what happens in polyuric renal disease?
Goes down.
Normal again, I think.
Goes down, exactly. So balancing the potassium supplementation based on what stage of renal disease they're in is really important. So 30% of cats will have a whole body hypokalemia, even if they don't have a serum hypokalemia in polyuric renal disease. So we often use amlodipine and benazepril in management of hypertension with renal disease. Do you know what effect amlodipine has on potassium levels?
I would have thought maybe let it go up, but I don't actually. Oh,
I guess go down.
I don't know.
Good, Alex.
I've got different kind of mindsets. Like maybe like if it drops blood pressure enough, it might activate RAS. But if it's also potentially bringing less to the kidney. Anyway, I don't know. Alex is probably right.
I'm just guessing.
Alex wins. I'm going to start doing quizzes and I'm going to keep score for who wins out of Alex and
I
Josh.
don't do that. That means I'm just going to lose.
You guys have a one.
You've done some really good answers today, Josh.
Yes. I don't know why either. Well,
I actually don't know why either, Alex, but it does.
Okay, cool.
So it goes down with amlodipine. What about benazepril?
I don't really know how benazepril works.
I don't know either.
50-50.
Max, help us out.
Maybe you need some points.
I think it goes down.
It goes up. Sorry.
Wrong.
But there's two medications we use really often, and it's if you've got a really hypokalemic patient, you're starting on amlodipine, that's the time to start potassium supplementation as well. And vice versa, if you've got a hyperkalemic patient, you're probably not going to be starting them on benazepril, but if you do, just be conscious that it could boost it a little bit.
Okay.
And is that because you're potentially decreasing the pressure at the glomerulus, you're going to have less potassium? That doesn't make sense. I don't know.
I think it's because of the aldosterone.
Yes, good. Yeah.
Yeah, because
Very
you
good.
put the RA
ACE inhibitor, of course. Okay.
Yeah.
So to increase potassium because it creates aldosterone.
No, opposite.
Okay.
1 point to
Very
me.
quick. Yeah.
That's the points.
So that then leads on quite nicely to the last point, which I think we should talk about, which is the acid-base balance. So if you had to say renal failure patients are more likely to be acidemic or alkalemic, which is it?
acidemia.
Acidemic, exactly. So they're almost always acidemic. So a whole heap of reasons for that. Can you mention any?
I think it's reducing reducing the tubular formation of bicarbonate that bind to the acid, that they can start reuptaking it.
Yes, so decreased bicarb reabsorption. Yeah. So proximal tubular failure, which leads to decreased bicarb absorption. Excellent. What else? Josh, did you say something?
I said a very lame version of what Max said.
Excellent. So the other one is they actually have increased lactic acid and decreased ability to excrete it, so they retain more organic acids. And the other thing, which is why I wanted to go straight from potassium to hydrogen, does anyone know how hydrogen and potassium interact in the kidney?
Are they swapped? Are they to try and like, oh no. Like potassium and bicarb kind of swapped with hydrogen in the kidney.
Potassium and bicarb, maybe. I can't actually remember. But essentially, when your body is trying really hard to excrete more hydrogen, it does it at the cost of potassium. So if you've got high hydrogen, like if you've got acidemia, you end up losing potassium while your body's trying to compensate for that. So acidemia will actually exacerbate a hypokalemia. So keeping that pH as neutral as possible is going to help to stabilize your potassium as well. And the nice thing is that the renal diets contain all of these things. So once we do get up to the point of being acidemic, the renal diet's so tightly kind of acid-base balanced, which is really impressive, the level of detail in there, that if we can get our patients on that, it's going to make a huge difference to their prognosis and electrolyte balances and appetite and all those things. And the only other thing really is moisture. So just making sure that they're well hydrated. So a tinned food as opposed to a dry food, or dry food with water on it, if the cats prefer pellets, is going to be much better for them long term than just dry food on its own. All right, we might wrap up.
Very cool.
Time for rounds.
Yeah,
Super.
Thank you.
That was awesome.
No worries. Cheers. Thanks, guys.
See you in 2 weeks. Thanks.
See ya. Thanks, mate. Don't forget your homework.
We won't.
Okay.
We won't.
Yeah.
Thanks, Anna.
Okay. Thanks, Jeff.
Bye.
See you soon. Bye.